Management of endometrial hyperplasia, Royal College Green Top Guideline number 67. Part 2. Management of endometrial hyperplasia. Management of endometrial hyperplasia without atypia. Initial management. So endometrial hyperplasia course over 20 years. 95% will regress spontaneously, while only 5% will progress to endometrial cancer. As we can see in this algorithm here, so we're going to start with endometrial hyperplasia without atypia. The first thing to do is to address risk factors. Reversible risk factors such as obesity and hormone replacement therapy should be identified and addressed if possible. Observational studies have demonstrated that up to 10% of severely obese women could harbor asymptomatic endometrial hyperplasia, and bariatric surgery may reduce this risk. Ongoing tamoxifen treatment should be reviewed in conjunction with the woman's oncologist. Many women with endometrial hyperplasia without atypia will present through postmenopausal bleeding pathways, and it is likely that they will have undergone a baseline pelvic ultrasound. If not, this should be arranged to exclude the possibility of an estrogen-secreting granulosa cell tumor of the ovary. If an ovarian cyst is detected on pelvic ultrasound, then blood for ovarian tumor markers should be obtained. In the absence of other risk factors for endometrial hyperplasia, a serum inhibin level together with an estradiol level may be considered if a granulosa cell tumor is suspected. So the next steps would be observation. Observation alone with follow-up endometrial biopsies can be considered to ensure disease regression, especially when identifiable risk factors can be reversed. Progestogens have higher disease regression rate compared with observation alone. So as we can see here in the algorithm, the following step after observation are progestogens, whether the intrauterine system or oral progestogens. Progestogens is indicated in women who fail to regress following observation alone, or symptomatic women with abnormal uterine bleeding. Medical treatment. Both continuous oral and local intrauterine progestogens are effective in achieving regression of endometrial hyperplasia without atypia. Progestogens have been advocated to treat endometrial hyperplasia because they modify the proliferative effects of estrogen on the endometrium. The levonorgestrel intrauterine system should be the first-line medical treatment because compared with oral progestogens, it has a higher disease regression rate with a more favorable bleeding profile, and it is associated with fewer adverse effects. The intrauterine release of the levonorgestrel minimizes the systemic absorption of the hormone and aids compliance by reducing adverse effects. In women of reproductive age, the intrauterine system can also provide effective contraception, and it is recommended as first-line treatment for heavy menstrual bleeding. Continuous progestogens should be used, whether medroxyprogesterone acetate or norecesterone, for women who decline the intrauterine system. However, cyclical progestogens should not be used because they are less effective in inducing regression of endometrial hyperplasia without a tibia compared with continuous oral progestogens or the intrauterine system. Treatment duration and follow-up. Treatment with oral progestogens or the intrauterine system should be for a minimum of 6 months to induce histological regression of the endometrial hyperplasia without a tibia. As we can see in the algorithm, so we address the risk factors and then we did observation and then we followed by progestogens treatment. The following step would be an endometrial biopsy to be taken at 6 months. If adverse effects are tolerable and fertility is not desired, women should be encouraged to retain the intrauterine system for up to 5 years, as this reduces the risk of relapse, especially if it alleviates abnormal uterine bleeding symptoms. So again, following the algorithm, after endometrial biopsy, there will be one of 3 clinical scenarios, as regression, persistence, or progression. And we're going to start with regression, so we have to review treatment. If we're using the intrauterine system, it should be continued for 5 years. If the woman is using oral progestogens, then she should stop after 6 months. Surveillance will be by outpatient endometrial biopsy, and this is recommended after a diagnosis of hyperplasia without a TB. Endometrial surveillance should be arranged at a minimum of 6 monthly intervals. Also, review schedules should be individualized and responsive to changes in a woman's clinical condition. At least 2 consecutive 6 monthly negative biopsies should be obtained prior to discharge. Again, looking at the algorithm. So here is a step arranging follow-up. If body mass index is less than 35, then we need 2 consecutive negative endometrial biopsies at 6 months intervals, then discharge. In women at higher risk of relapse, such as women with a body mass index of 35 or greater, or those treated with oral progestogens, 6 monthly endometrial biopsies are recommended. Once 2 consecutive negative endometrial biopsies have been obtained, then long-term follow-up should be considered with annual endometrial biopsies. Again, we are looking at the algorithm following the steps, and here we can see the part with body mass index above 35. Relapse. Women should be advised to seek a further referral if abnormal vaginal bleeding recurs after completion of treatment, because this may indicate. So we're following the algorithm, and if we're reviewing treatment, arranging follow-up, and then relapse occurs here. Surgical management of endometrial hyperplasia without a tibia. Hysterectomy should not be considered as first-line treatment for hyperplasia without a tibia because progestogen therapy induces histological and symptomatic remission in the majority of women and avoids the morbidity associated with major surgery. Hysterectomy is indicated in women not wanting to preserve their fertility when progression to atypical hyperplasia during follow-up, no regression of hyperplasia despite 12 months of treatment, relapse of endometrial hyperplasia after completing progestogen treatment, persistence of bleeding symptoms, the woman declines endometrial surveillance or compliance with treatment. If we look at the algorithm again, these are the indications. So either progression to atypical hyperplasia or endometrial cancer, or there is no regression after treatment, or there is a relapse, or there is a persistence of bleeding symptoms. So the nomenclature here. Regression means non-hyperplastic or non-malignant endometrial sample or non-diagnostic endometrial sample from an appropriately placed endometrial sampling device. Persistence means no regression or progression of initial endometrial hyperplasia subtype after 3 months or more. Progression means development of atypical hyperplasia or endometrial cancer. Recurrence means recurrence of endometrial hyperplasia without atypia or atypical hyperplasia after 1 or more negative endometrial biopsy results. Regarding ovaries removal, if the woman is postmenopausal, then the recommended treatment should be bilateral salpingo-oophorectomy with a total hysterectomy. However, if she is premenopausal, then the decision should be individualized, and bilateral salpingectomy may reduce the risk of future ovarian malignancy. The treatment is total hysterectomy, so there is a laparoscopic approach and an abdominal approach. The laparoscopic approach carries several advantages as quicker recovery, shorter hospital stay, and less postoperative pain. Endometrial ablation is contraindicated because complete and persistent endometrial destruction cannot be ensured, and intrauterine adhesion formation may preclude future endometrial histological surveillance. Thank you for your attention.